validity testing, which is really helpful. Sorry, that's my husband. So the benzos were not on the confirmation on the 19th, a week later. He says that he is treated for depression and sleep disturbance with Buspar. Well, that would be anxiety. Anyway, he says he's on Buspar, and I think he says he's on trazodone, but I don't see that in his chart. And our chart pulls, our EMR pulls from pharmacy records. So I have never been able to verify that. And he tends to be a little not clear when he's talking about what medications he's on. He doesn't quite remember the name. He doesn't tell us who's prescribing. And he, at one point, said that, maybe this was last week, said that his UDS had benzos because, because of his buprenorphine, because of his Buspar, which I don't think is possible. So at any rate, what we did after he told us about the prescriptions from the dentist, I explained to him that we really needed him to communicate with us when he was being prescribed controlled substances by another provider. And in fact, he had signed an agreement to that effect at the induction of his treatment with us. And that because he had not, kept that agreement, we decided to keep him in treatment our weekly program for an extra 30 days beyond what we usually would. So usually after 30 days, they go to biweekly group. He was right at 90 days. He was at 83 days when this all came up. And the team decided to recommend that he continue in the weekly group for another 30 days. And this was partly because we felt that he wasn't real straightforward about communicating with us about the Valium and hydrocodone. We talked to him about the risks of those two drugs and of stopping his Suboxone. And also because he just, it's sort of a pattern of not taking the program requirements seriously. We decided not to put him in IMED again because we thought he probably wouldn't be able to make it. He doesn't have good transportation. We thought he would just drop out. So we thought that this was a good program, a good compromise to have a message to him about the importance of communicating about his medication and taking it as prescribed and communicating if he wasn't going to, but without putting an undue burden on him. He was very angry about that, and he eventually calmed down. He did show up this past week, the 19th, and was very jolly. When he's not really angry, he's very pleasant and almost jolly. And so that's the story without belaboring a lot of it. Can you scroll to my question? Oh, there are my questions. So I think it's a really interesting case to be able to discuss how to treat potential pain or anxiety related to a dental surgery, which is, short term. And I would like some assistance with that. I think if the dentist had called me, I probably would have had him stay on his Suboxone and try Tylenol. And I might have thought it was okay to give him a little bit of hydrocodone if the Tylenol didn't work, but I don't think I would have stopped the Suboxone. And I don't know what I would have said about the Valium. I mean, he already has Buspar. I'm not sure if I would have. I might have asked them not to prescribe the Valium, but I don't know. So anyway, I'd like some feedback on that. And then we really, gave him this extra 30 days in the weekly program because we felt that it was a pattern of him being somewhat evasive and not communicative with the team and so on and so forth. But, you know, it does raise the question of if a patient is not meeting program expectations about communicating, but he's following the advice of another professional, you know, this is kosher to sanction him or whatever for that. And then the last question I have is just about this question of the previous TBI, and it's sort of haunted me is some of the way he behaves towards us, not some kind of resistance or, but is it in fact as a result of, you know, this brain injury, and should we be formally trying to diagnose that? Anyway, so that's pretty much, I know we have a full day, so I won't go on and on. That's the gist of the case.
Thank you so much, Jen. That was an awesome case presentation and definitely a great one for discussion. So thank you. Before we go into the recommendations and feedback for Jen's case, did anyone have any clarifying questions for Jen? Feel free to unmute or chat in. All right, and any hub members with feedback, recommendations, comments, and I'm happy to pull up the case again for the questions.
So Jennifer, I work with the high-risk pain clinic over at the Center for Integrated Pain Management at WVU. And it's very common that we have patients who are being treated for both opiate use disorder and chronic pain with Suboxone, and then have a procedure, you know, a surgical procedure, some kind of painful procedure, and require some kind of analgesic, additional analgesic treatment on top of their standing dose of Suboxone. And so it's possible to use, you know, like 2 milligrams every 4 hours, PRN of additional buprenorphine to treat acute pain. And so that's one option, is to have additional Suboxone available. And for someone who has like a wisdom tooth extraction, maybe 3 days worth of medicine, so, you know, not a terribly long course of additional analgesic medication. And then he can communicate with you about how he's doing and let you know if there's a problem. But the key to it, Jennifer, is to divide it up through the day. So the analgesic effect of buprenorphine is 4 to 6 hours, sometimes 8 hours in someone with chronic pain, but usually around 4 to 6 hours. And so you want to divide it up into, you know, TID or QID dosing, or, you know, every 4 hours if necessary. Okay. And then as far as this guy's cognitive issues, so he has memory problems and he escalates into anger. You know, this is sounding like, you know, maybe the injury to his brain has caused some psychiatric sequelae. And so maybe neuropsychiatric testing would be a wise thing to do, just to see what his deficits are and, you know, how to manage. You might have to have some unique kind of approaches to managing him. You know, if he can't remember what his medicines are, and, you know, he may not remember what he signed in his contract with you at the induction about, you know, how to handle his pain, you know, if there was pain, how to handle that with your program. So
Right.
You know, he's a unique case. I think there are patients who just, you know, don't follow the instructions, but this guy clearly has some kind of cognitive limitations. And so maybe, you know, it wasn't, you know, a manipulation or a malicious kind of intent. You know, I think maybe just kind of not knowing is what I would suspect.
Yeah, that's what my concern was. That's helpful on the pain, and you do that on top of his current buprenorphine dose.
Yeah, so even though he's on 16 milligrams, but there's kind of a bit of wisdom in the pain field that adding additional Suboxone above even where you think you're saturating the mu opiate receptors can give you acute analgesic relief. So there may not be a ceiling to the analgesia that you can create in an acute situation.
That's very helpful. And what do you think about the Valium?
Yeah, so dentists give people, you know, benzos to relax them because they're afraid of having a dental procedure. So, obviously that's not a good idea and somebody's on an opiate, so we don't typically do that. That could have been handled in some other way, to have him deal with his anxiety about the procedure.
That's all very helpful. Thank you.
Yeah.
We've had similar patients, and we've handled it both ways. One, we had a guy who had dental surgery. We went up in the Suboxone and made sure they added some NSAIDs. But for some of our other patients, going up in the dose, that is not really helpful. And they actually know. So you can actually ask your patient, because a lot of them have already experimented in going up before or not when it comes to simple things like pain. And so for those people, we actually have to stop, hold the Suboxone a day or two before, then they just get their hydrocodone. And for some people, they do have extreme anxiety surrounding procedures because doctors have not seen that before. And we have allowed a benzodiazepine dose for the procedure. And as long as they're clear, it's just 1 or 2, I mean, it's not a problem. But what you should know, stuff like Valium can last in the urine, the metabolite, for 1 to 2 weeks. So that one dose can actually be there for quite a while.
Thank you, Dr. Bell.
One last thought. If he could sign a release, if you could just get the information from the dentist, you can take some uncertainty out of what happened. Because I know you were questioning, what happened there. So you can get clarification of that. That would be a nice thought.
Good idea. I wondered about calling the dentist. I don't think I have anybody else who sees this guy, but in the spirit of, teamwork in our community, and just, it will probably never come up again, but it seems as though we should be talking to each other.
Yeah, and that was, what I was thinking is to communicate with the other provider. That is what I have done before, of communicating with the provider as to what they can do. And sometimes there is a lot of counter transference from the other provider also, because they are on MAT, they would not give them pain medications, and patients are told about that, and the patients freak out. And then we call the provider, talk to them, kind of explain it to them as to this is what we are going to do. It's okay to give pain medications, and just kind of work with them. So I think that's one of the options we can take too, working with the other provider.
Thank you.
I agree, Jennifer. I've actually for our other providers that see my patients that are on pain medicine, particularly my pregnant women, when they get their C-sections, I have a dot phrase that I just send them. Please call me if you have any questions. I will help you with this. And by the way, you can do this, this, and this. Give them ibuprofen. Give them, they can have extra Suboxone, which I'll provide, or they can also get additional narcotic analgesics as well. You don't always have to stop it. You may need higher doses, but again, that's the less preferred method, but there are different ones. And so just educating your community little by little, it helps, and they'll probably appreciate it, because they do feel trapped with, the perception of giving pain medicine to people that have addiction and taking care of their pain.
Thanks.
Thank you all so much. And Dr. Baltiera, I'll add the best practices link in the chat in the recap email for everyone to have. Were there any other recommendations or feedback for Jen's case? From anyone, feel free to unmute or chat in. And Jennifer, did you have any other questions you wanted to ask about your case before we go to the second case?
No, I really appreciate the help.
Awesome. Well, thank you so much. We appreciate you. All right. Thanks, everyone. Dr. Bo, I know you have a case as well, so I'll go ahead and share my screen and turn things over to you anytime you're ready.
Okay, so I would love to hear you all's opinion on this and get some feedback. So because we had the situation with actually 2 patients. Let me turn off my heater, but I'm only presenting the case for 1. We have a 31-year-old white female. She has been a part of our program since 2018 and maintained on Suboxone 16 milligrams daily. And how she took hers, she actually would divide it up 4 times a day. She was in sustained remission for years without relapse and very compliant. But then she started to relapse to cannabis in the summer of 2021 because of overwhelming anxiety and depression. So she started to see a psychiatrist in order to treat the anxiety and depression. And then around maybe November, December, she went, hey, I'm interested in Sublocade. I'm tired of taking this medication. I spit it 4 times a day because I'm so anxious over things. And it's a mental barricade. So I want to go on Sublocade so I don't have to take this medicine, which reminds me I have to take a medicine every day. So we said, okay, sounds good. We've transitioned her to Sublocade, and it did not go well for her. She did not tell us until the second dose, but she said during the first dose, she was okay for the first couple of days, and then she started to get withdrawal symptoms, sweats, tremors, cravings, and especially around the time the evening came when she would usually take her last strip of Suboxone. But she said, she told herself, well, you know what, this is you being weak. I don't want us to change. So she went ahead and got her second dose of the 300. And thankfully, her therapist is in very good communication with us. And she called and said, hey, she's not doing well. She's having these symptoms. She's actually getting Suboxone from the streets, and she was really concerned. So we told her, well, come on in, we'll just talk to you. So she felt guilty and ashamed, told the therapist, and the therapist told us to tell us what was going on. So what it was important that she started getting treated for anxiety and depression with the Effexor. She started as 37.5, and it was increased by the time she got her second dose to 75. Significant in the social histories, she was born and raised in West Virginia. She's married, has a kid, is presently working. And in terms of her mood symptoms, she's had multiple treatment failures in terms of sertraline, citalopram, fluoxetine, paroxetine, and the Effexor was her jam. She said she noticed a big difference in anxiety and depression, so she didn't want to go off of it. Comorbidly, she has lupus, eczema, seasonal allergies, and hypothyroidism. So we brought this lady in thinking, what on earth is going on, right? Because Sublocade is supposed to be super awesome, saturates all the receptors. You're not supposed to be going into any withdrawal. But when I was looking over some of the side effects of it, it made me think that maybe she was having a side effect or interaction with the medication. So I brought her in on Friday. Her vitals were stable, a general exam unremarkable. But what we did find, she had a tremor to outstretched hands. She had hyperreflexia. She had inducible ocular clonus, which is very mild, and no fever. Okay, so the question I know what I was thinking, but the question to you all, what would you have done? What are you all thinking? Have you all had similar experiences with this? One of my initial thoughts was, boy, something must be wrong with the Sublocade batch, because we had 2 patients with the exact same presentation. And we were trying to figure out how do I track down the lot? How do I figure out if the Sublocade batch is working? And then we did a little bit of reading and started to wonder, is this a problem with her Effexor or not? So we thought, or like when I saw her, she definitely had serotonin syndrome. I've seen it a couple of times. She was right on the money for it. And then when I looked at the side effects of Sublocade, lo and behold, serotonin syndrome was there. And what she said was so interesting. She said every time she took the Effexor, 4 hours later, like on the money, she started to have these overwhelming feelings and signs of the withdrawal, the shaking, the sweats. And then when she went up on her dose, that's when it got unbearable. And that's when she started to go to the streets and get the extra Suboxone. So feedback, what do you guys think? Any pharmacists on the line? Tell me what to do.
Thank you so much, Dr. Vogt. Awesome case presentation, very interesting as well. Did anyone have any clarifying questions before we go into any of the feedback or recommendations?
So her symptoms started after she was started on Effexor?
Sublocade. She started Effexor, yeah, a month before she got the Sublocade. And when she got the Sublocade, that's when the symptoms start.
Okay.
Yeah. You were out last week, sorry.
Yeah.
I would drag you in the room too. Yeah, so this case, maybe go and read up like CYP450 enzymes. And then, because like a third of people don't respond to opioids, and 2D6, you have problems with 2D6, you're gonna have problems metabolizing medications. And so it made me wonder, like, well, is she abnormal metabolizer of 2D6? And is she having an abnormal serotonin reaction with the Effexor and the buprenorphine? And have you guys ever seen this? So at the same time in that group, we had another patient goes, oh my God, I had the same thing happen to me. And I was like, no way. So that's what made me think there was something wrong with the batch. But when I went through her medication list, she also was on a super high dose of Zoloft. Well, the max dose of Zoloft, but with the same symptoms, which they interpret as withdrawal. But when you see them physically, it's more in keeping with serotonin syndrome, which feels just like withdrawal.
I don't know about anybody else, but I found this case extremely interesting.
And Mark, I'm so glad you're here.
I think Mithra or somebody sent it out on Friday, and it was like towards the end of the day, and I was like, ah, hell, I'm going to work a little extra today because I want to look into this. So there's a lot of stuff that goes into the pharmacogenetic side of it all. There's actually 3 different guides or guidelines that are out there. One's the FDA, one's called CIPIC. I can provide these later or in the chat or whatever. And then there's another one from like either Holland or Germany or one of those guys over there. CIPIC, CPIC is typically the main one. I looked up things for this in there, and one of the tricky parts is that it's not just CYP 450 that comes into play for pain meds or even addiction medication and whatnot. There's other ones in the background. There's this COMT, there's another one. I'm sorry for the lack of specificity, but the bottom line of the recommendations are that there's no recommendation with it. Hence why I didn't remember the alphabet soup. So that's up a tree, up a creek, whatever. That doesn't give anything. So then it starts wondering like, okay, well, buprenorphine's 3A4, Effexor, venlafaxine is 2D6, like you were saying. 3A4, if you look through any of those guidelines for PGX, pharmacogenetics, there's really nothing. But 2D6 is one that does have recommendations, of course. Typically highlighted with things like codeine, tramadol, because it's a prodrug, in that regard. There wasn't really anything as far as her medications in this particular case, but it still comes into play because now we're talking multiple ones. Now, buprenorphine with other serotonergic agents can certainly have a serotonin syndrome risk. It's one of those where usually we say like, oh my goodness, there's the pharmacist yapping about serotonin syndrome again. But I have the benefit today of saying, well, it already happened. So yeah, we got that going for us. Whereas it could have been a conversation to say, FYI, could be a risk. How I normally go about that is just saying, hey, especially these days, everybody knows about flu and all that stuff. Just say, hey, if it's Friday and you feel like the flu, don't wait till Monday to let us know. Just, a little bit earlier. Or don't wait 6 months or whatever this was, because like in the last case, the communication is really important. But buprenorphine, it's not usually identified as a serotonergic opioid, but there's case reports. There was a few I remember seeing, not for this case in research, but in the past. And there's a general push to say, hey, just watch with that. And that might be, here you got a room of a handful of people and 2 hands were going up, I guess, for an SNRI, SSRI, I forget what the other one was. And it brings that to the forefront of just, 2-3 weeks ago, there was the headline about, oh, for oral buprenorphine products, you got to tell people to like rinse their mouth and then, and all that stuff. And it's like, to me, I'm like, okay, that's important. But then something like this, why don't we have a random headline for that? Clearly, not all of us have this on the tip of our tongue. So it is an important thing to remember. As far as the PGX or the interactions, there really wasn't anything coming out with that. It's really seems like it's just one of those, quite frankly, you hit on the head of the serotonergic concerns. And that's really that. I'm a little baffled though on and I don't think I'm alone, on that need for multiple dosing. That's where I was really looking as far as any of the metabolic concerns along the way, to just say, why, like, what's going on here? Drawing a blank there on anything I was looking up. So, and from experience, of course. So I don't know if anybody else had anything else. I just talked for like a good minute there, but.
Yeah, you know what we did? We got gene tested in her just to see.
Yeah.
I can't wait for that to come back.
Yeah. There's so many things that go into that. There's the transporters. There's the CYP 450s. We all usually come down with those things. I mean, in pain addiction, it's 2D6 and 3A4 are your big ones. With 2D6 being one of those that really comes out for it. Every time there's a class or a CE on PGX, they should include the codeine or tramadol or whatever. But this one's a tricky one. Just the need for the multiple daily dosing is just, oh my goodness. And then on top of that, you got all this serotonergic activity. Like, this is too hard for boards. I wouldn't recommend it for a
Thank you so much for that feedback, Mark. That's excellent. Did anyone else have any feedback, comments, recommendations?
I was just going to say about Sublocade to Dr. Bowe. I don't know what your experience with Sublocade has been, but we've been prescribing more of it, and we find that people that have been maintained on the higher doses, like 16 or 12, that there is a huge adjustment to Sublocade. It doesn't line up exactly the way the manufacturer says that it's, equivalent to 16 or 24 even. I think that's something we're kind of getting to know, that maybe Sublocade is better for people that are more naive to buprenorphine and haven't been on it for super long time. So I'm wondering if just the medicine itself maybe is not the best choice for many. If you ask the manufacturer, they'd say switch everybody to Sublocade. It's a perfect drug, but we're definitely not seeing that. So just another kind of component to this.
Thank you so much, Dr. Houston.
And an added note for that, if there ever was a contemplation to switch over even further to something like methadone, I mean, methadone's metabolism is, yes, all the above, of course, but the main one is 3A4, which is also the main one for buprenorphine. So,
Thanks, guys.
Any other thoughts or comments from the group? And Dr. Bowe, were there any other questions you wanted to ask about your case?
Any other differentials that you all could think about? So I want to make sure I'm not missing anything, because what surprised me is when she said she went and got Suboxone from the streets, and I'm like, wow, Sublocade has blocked all the receptors, so what good is that? And so I did ask her, was it helpful? She went, nope. But she couldn't make herself not do it.
Silence is good. That means everyone's thinking.
Dr. Bowe, the only other thought I have, and you've probably thought of this, is just maybe check her thyroid level. So she's on that. That could mimic some of the symptoms. Probably not, though.
Thanks.
Thank you, Dr. Reynolds. Anything else from the group before we go to the didactic portion? And as always, if there are any feedback, comments, questions after the fact, just chat it in the chat box or shoot us an email. Alrighty, well, Laura, I'll turn things over to you for the didactic. Oh, you're already on it. I love that. I'll turn things to you now. Thank you.
Hey, everyone. So we're going to switch gears a little bit and talk about treating pregnant women with substance use disorders, and specifically pregnant women with opioid use disorders, but also generally co-occurring use disorders. And I'm going to share a little bit about the model we use in Morgantown, which is based on the COAT program, but also incorporates a centering approach, which I'll explain a little bit. So in general, just positive outcomes for pregnant women with substance use disorders in terms of getting them into treatment helps mom and baby. So decreases active substance use, increases attendance at prenatal care. So it has a positive impact on that. reduces overdose and death, improves neonatal outcomes, and decreases co-occurring infectious diseases, usually associated with intravenous use like HIV, hepatitis C, and endocarditis. So we want pregnant women to come into treatment who have substance use disorders. And in particularly, the centering approach has gotten more attention recently, and it actually came a little bit out of pediatrics. And so centering is really refers to a model where you are combining treatment providers from traditionally separated disciplines like OBGYN and behavioral health, or behavioral health and pediatrics, into the same treatment team. And what happens is it really helps with communication, transparency of care, and consistent recommendations. So you could have a centering approach with a dental clinic, right? And then you wouldn't run into some of the problems that that Jennifer encountered, because everybody would be making the same treatment recommendations to patients. And what you can imagine, when you have pregnant women seeking care from OB providers, pain management can also be a difference that we see, as well as breastfeeding recommendations and all kinds of other recommendations. So being on the same page and not confusing patients has been found to be very helpful. And our particular centering approach really combines these different things. So obstetrics and gynecology and behavioral medicine. So we're all on the same team. We are in treatment team together, and we're in med group together. Our ACE program, which stands for Assist, Connect, and Encourage, and that is a state-funded program that really helps women, pregnant women with substance use disorders, and is embedded in OB care in about, I think there's 17 programs across the state. And that includes, they have a peer recovery coach and a patient liaison that can help with some intensive case management. We also coordinate with pharmacy pretty directly. And we've also coordinated with the Child and Family Law Clinic, because many of our patients are involved with Child Protective Services, which is a huge stressor, both in pregnancy and postpartum. So that's just a little bit about centering. Just reviewing prevalence. So these are some older numbers, and I'll get to some more updated numbers. But in general, these have stayed the same. Younger women use at a slightly higher rate than older pregnant women. And what really brought the study that brought this into the forefront with regard to the rates of substance use disorders among women, pregnant women in West Virginia, was the Stitley study in 2010, which is very dated now, but it was like the shocker. It was like, 1 in 5 pregnant women are using substances, which was really not known in 2010. And this is based on, data from 2008 and 2009. And so that was the study that really brought this to the forefront. And we want women to get into treatment who are pregnant, because it really does improve birth outcomes. So when we look at what's it looking like over the last couple of years, this is from National Survey on Drug Use and Health from 2020. It's not huge changes. Good news is opioids have actually decreased. So the prevalence of pregnant women using opioids is going down. What's not shown on this slide is, like, for the general population, use of methamphetamines is going up. Tobacco products is going down. Marijuana is going up a little bit. And alcohol is kind of holding steady. And so this is the overdose death slide that many people have seen about what's driving overdose deaths, and synthetic opioids and stimulants really taking a huge surge in 2016 and 17. And we do know that these deaths have continued to rise, and they've continued to rise among pregnant women as well. They really don't differ from the general population in terms of the trends in use patterns. So this was a study that was done in Massachusetts, which is really interesting because it speaks to the window of opportunity during pregnancy. And it's almost a little bit of a safe space. So this is about overdose deaths. And if you can see the slide, the overdose deaths really decrease. And this is both non-fatal and fatal overdoses actually really decrease in that second and third trimester. And so if we can get women into treatment and hold them in treatment, they're more they're less likely to actually engage in use and be at risk for overdose after treatment. One of the things we know is that many women drop out of treatment after they deliver because the primary motivation to coming into treatment was that they were pregnant. So retention in treatment is not only extremely important during pregnancy, but in the postnatal period also. And just a reminder that we're looking at not just opioid use disorders, but often co-occurring substance use disorders. And these are the most frequently used substances co-occurring with opioids, and not to forget about gabapentin in there. General adverse outcomes, we're looking at low birth weight, severe NAS, nicotine use rates are very, very high and associated with low birth weight and restricted growth. So we also get to incorporate nicotine replacement therapy into practically every group session that we have with pregnant women as a way to really help them feel like they may be able to impact neonatal abstinence syndrome as well as the health of their pregnancy. So the other thing that treatment helps with is all kinds of birth outcomes. So this is just a graphic that I think is really clear with regard to patients, pregnant women who do not have any addiction disorders, and then pregnant women who have treated substance use disorders versus untreated substance use disorders, and the significant differences in all of the birth outcomes that are kind of the ones we pay most attention to. So treatment really, really is important during pregnancy. So many of you guys work with pregnant women with substance use disorders, and I know Dr. Baltier is here, so feel free to chime in at any time. But Dr. Marshallek and I started the pregnancy clinic in general 11 years ago now, which is kind of crazy to think about. And then we started our centering model about 3 years ago, 3 or 4 years ago, and then the pandemic hit and it put a little bit of a damper on that, because we used to do things like provide healthy food for the women when they came to treatment, and that's difficult to do on tele. But what we found is, pregnant women with substance use disorders are motivated in a different way, and they typically are quite highly motivated when they come into treatment. Often, women won't necessarily seek treatment for themselves, but they'll seek treatment for someone else, and when they're pregnant, the someone else is the developing fetus. They can be, and that helps them resolve their ambivalence about whether or not to discontinue use. Population tends to be younger, so they may or may not have a shorter progression of the disease. They often have family support, so families rallying around in the time of pregnancy, and have a sense of hope that they had not previously had, and also a higher level of willingness to follow recommendations. So it's really, as I said, a window of opportunity with regard to treatment. Some of the challenges is we see fairly high rates of intimate partner violence, whether it's past or present. Very high levels of guilt and shame. Why couldn't I quit for my baby is something that people articulate. Tremendous fear of child protective services, which keeps people from seeking treatment because they are afraid that if they admit they have a problem, that people will remove their children if they have other children, or will immediately remove their baby when it's born. Often women don't also come into treatment right away because they don't realize they're pregnant, because for women who use substances pretty heavily, this can impact menses, and they don't menstruate. They have childcare issues, transportation issues, economic and financial issues, employment issues, certainly at risk for medical complications in the pregnancy. And then I would say they're probably the most highly stigmatized population. So we know that individuals with substance use disorders are highly stigmatized by healthcare providers, and pregnant women with substance use disorders are even more so. And then there's post-delivery challenges to think about, huge increase in relapse rates after delivery, often because of the stress of delivery, stress of child removal, or guilt and shame about, am I a good enough mother? Can I be a mother? And there's a lot of family stressors that can happen too. So this is when we see those higher dropout rates, making sure we're looking for postpartum anxiety and depression is really important. There's often negative family interaction. Sometimes patients don't let their family know that they are on medication for substance use disorders. And when they find out, if they find out, the family is often very angry. There's the risk for neonatal abstinence syndrome, CPS involvement, and possible child removal. And that guilt and shame that really drives women out of treatment and can prevent them from entering treatment. And this can be exacerbated by interactions with healthcare providers, which is, again, one of the benefits of combining kind of the OB provider with the behavioral health treatment. So I know I'm short on time, so I'm going to run through some of these quickly because I think you all know them. But these are the different kinds of treatment. So inpatient, residential, outpatient, and medication for opioid use disorder. So there are still some folks out there doing detoxification of pregnant women. And it's not that you can't detoxify pregnant women safely and keep the baby safe. It's that the relapse rates following detoxification are very high, which puts both mom and baby at risk. So this is why it's not recommended by ACOG or the addiction medicine experts. You guys also probably know, we've been over this in here before, the medications for opioid use disorder in pregnancy are similar to those in the general population. So naltrexone is still not FDA approved, but there's growing evidence to suggest that naltrexone does not have any negative impact on the developing fetus. So that is under study. We used to certainly think that we had to prescribe Subutex because of the naloxone in the combination product. And there have actually been enough research. These are some recent studies looking at this that have shown there's no negative impact on the developing fetus and that neonatal outcomes are the same on buprenorphine, straight buprenorphine or the combination product. So risk versus benefits, there are always risks to taking medication when pregnant, but as the lists kind of illustrate, the benefits typically outweigh the risks. I think you guys know the benefits. They're similar to again, non-pregnant patients, although you know, the fetus really benefits from having that intrauterine environment stabilized in a way that taking short-acting opioids or using other substances to achieve intoxication destabilizes that environment. So the neonatal abstinence risk is certainly real. I know we've made great strides in the last, in the last 11 years in the treatment of neonatal abstinence syndrome. We have new ways to assess for it that involve the patient in that process, called Eat, Sleep, Console, which is much better than the 26-point Finnegan score that used to be worked, which was really felt very stigmatizing to patients because basically they came in, they pushed the mother out of the way figuratively and examined the baby, and it felt really terrible to patients. They would describe how the assessment was done. And now with Eat, Sleep, Console, the nurse involves the mom in scoring the baby on just those three measures, which is how's the baby eating, how's the baby sleeping, and can the baby be soothed. Much more intuitive as well. I know at WVU, we no longer always treat severe neonatal abstinence syndrome from opioid use disorder or buprenorphine exposure with a long course of medication. It's been found that actual periodic rescue doses can help stabilize the baby's nervous system, and you don't have to get them on a 2-week taper. And so they don't have to have long hospital stays as a result and can stabilize much more quickly. Pain management issues, like with any surgery, especially if mom has a C-section, can be a risk. And this is again why when being on the same team is super important to make sure we're giving patients the same recommendations. Risk of abuse and diversion of medication, like with any patient, is a risk of being on MOUD for pregnant women, and familial conflict or disagreements about whether or not they should be on medication while pregnant. So just a little bit about our centering program. What's highlighted in green is what makes it different than regular COAT. So regular COAT is weekly medication management, group, drug screens, individual therapy, strip counts. But we actually have a peer recovery coach that's embedded in our groups, and she has weekly Zoom meetings that the women can attend that's outside of treatment, which has been really helpful. We have a nurse midwife that's the prescriber on the COAT team, and so she not only fields medication questions, but also breastfeeding questions and questions about what to expect and questions about why do I have this pain here. And so it's really nice to have all of the patients' questions answered in kind of a one-stop shop. Nicotine replacement, as I mentioned, and there's a huge emphasis on retention in treatment. And so sometimes the requirements are a little bit more flexible with this group than they might be in the regular COAT clinic, because we're really trying to retain women in treatment, especially during pregnancy. So if people aren't familiar with the ACE project, so this is a project that began in 2012 with 4 sites that were funded by the Perinatal Partnership, and it's now expanded to 17 sites with additional funding from SAMHSA and DHHR. And it's a tremendous resource for our moms, and they really do a great job with intensive case management, essentially, as well as the peer recovery coach piece. And then in general, one of the things I love about working with pregnant women in groups specific to pregnant and postpartum women is we get to talk about all the pregnancy stuff and the postpartum stuff that sometimes other group members do not want to hear about when we used to treat pregnant women in mixed gender groups, or even in mixed women groups. You know, some women are not interested in hearing about all the pregnancy and postpartum stuff either. So we get to talk about what to expect during delivery, pain management, nutrition during pregnancy and postpartum. Certainly child protective services ends up being a significant topic. And it's interesting, I have a group full of women now who are in all different phases of CPS, including no involvement. And so it's actually the most diverse kind of group, like people who have had their rights terminated and are likely to have their rights terminated with the child that's about to be born, versus people have full custody of all of their children. It can make for some lively conversation. Impact of medication on the fetus is something we talk about all the time in group, neonatal abstinence syndrome and breastfeeding. So sometimes there's a fair amount of misinformation among OB providers, and what we tell people in behavioral medicine groups about the safety of breastfeeding on medication for opioid use disorder. So we do encourage breastfeeding as long as people are not using any other substances. And then parenting obviously comes up a great deal, and bonding with infants. So these are kind of the typical topics that we talk about. This is a great resource, and I know that Mitra is going to put this in the follow-up recap at the end if people are interested in learning more. And this is available as a PDF online for free if people want official SAMHSA clinical guidance for the treatment of opioid use disorder. And I think that's it.
Thank you so much, as always, Laura. Great presentation. And I know we do a presentation on stigma, but I think we could do a whole presentation didactic on this PPW pregnancy COAT stigma in itself. So thank you so much. That was wonderful.
Did I miss anything, Dr. Baltier?
You got it all, and you can tell you like doing it. Only a comment is, a lot of people are afraid of pregnant women. I actually find it much easier. They're motivated. Occasionally the ones that aren't is very hard. but I think most of our patients are very motivated. I think they're easy. The outcomes are good. And I'm glad that Morgantown's moved. Are they not using the Finnegan score at all anymore, or
We are, I got
they
word
modified it?
Yeah, I got word last week. We are officially transitioning to Eat Sleep Console, which I'm very, very happy
good. Yeah, because we've been ignoring it a little bit, but you know, it's hard. It's nice when you guys do something official, we can follow and have your backing. But yeah, it's a good field.
That's awesome. Thank you so much for adding that, Dr. Baltiera. Any questions, comments? I know we're at 5 p.m. now, so I don't want to hold you all, but did anyone have any comments or questions? All righty, well, thank you all so much. This was an awesome session as always. I thank all the case presenters and Nora for presenting the didactic. My only announcement is that our next session will be on February 14th, and Dr. Husted will be presenting on dosing of medications. So keep an eye out for that reminder, and I hope you all have a wonderful evening. Thank you.
Thanks, everyone.